Today we're going to talk about the endocrine system. Yay! Now, the endocrine system really intimidated me at first, but I'm starting to get more used to it, and so I feel a little better about it. But you can trust me, okay? I will help teach you. Now, first, let's talk about the thyroid gland. The thyroid gland releases 3 hormones, T3, T4, and calcitonin. Now, calcitonin takes calcium from the blood and puts it back into the bone. Great for osteoporosis patients, right? Okay, now, you need iodine to make these hormones. Now, I'm referring to a dietary iodine. And here in the USA, we have plenty of dietary iodine to make our hormones, right? Yes, we do, but in other countries, not having enough dietary iodine might be a problem. Now, the thyroid hormone gives us energy! Yes, energy, energy. Go thyroid, give me energy. Okay, I'm sorry. Now, hyperthyroid is having too much energy. That's right, too much energy. Now, I don't know anybody that has hyperthyroidism and too much energy, but I'm going to let you in on a secret. I do know somebody at the ballpark, okay? And she is very sexually hyper energy with some of the other women's husbands, okay? So, her last name is Graves. So, when I think of hyperthyroidism, having too much energy, I think Graves. And that's exactly right. Graves' disease is having too much energy, hyperthyroidism. Now, I think about also having too much energy. It's going to make you kind of nervous, okay? Going all the time makes your weight decrease. You get sweaty and hot because you're going so much and using up so much energy. And you can have the exthalmus, which your eyeballs bulge. And this is irreversible. So if we can, we want to try to keep this and catch it before it happens. Okay? Now, the attention span is decreased. Your appetite is increased because you are expending so much energy. You might be irritable. Your GI system is sped up. Your blood pressure is going to be high. Your heart rate is going to be increased. And your thyroid gland actually increases in size. If you were to do a thyroid scan, you would see a big old thyroid, okay? But before your thyroid scan, please remember, stay off of iodine medications at least 1 week, okay? Now, if you drew a serum T3 and T4 level, would you expect those to be increased or decreased? That's right, increased. Now, let's talk about some treatments for Graves' disease. Now, we're going to keep referring back to this Graves' disease thing because with this whole entire endocrine system, well, just with the thyroid gland, I really have a lot of examples to remind you of this Graves' disease, okay? And the whole little storyline. Hyper at the ballpark, okay? Now, I'm going to suggest that you know your medications. First, anti-thyroids. These stop the thyroid from making those hormones, okay? Now, one little neat trick I want to tell you about. The first one is called PTU. I can't really say it as well as I need to. That's why I like to call it PTU. But it's propylthiouracil, okay? The second one is methimazole, also known as tapazole. Okay, now, one really great thing about these is right in the middle of these big words, it has THI, which actually reminds me of thyroid. thyroid gland, okay? Thyroid gland. Now we know that the thyroid is spelled T-H-Y, but these have T-H-I, which reminds me that these are anti-thyroid medications. Anti-thyroid have T-H-I in the middle, and they keep the thyroid from making hormones, which is great pre-operative because it stuns the thyroid, okay? Now, we want this client to become euthyroid, which means means normal. So we want the thyroid function to become normal. That is our goal. Now, the second type of drugs I would like to discuss with you are iodine compounds. Now, iodine compounds and the dietary iodine that we take are two different things. We're not even talking about the same thing. And here once again, the name gives it away. Potassium iodine or strong iodine solution, better known as Lugol's solution. Okay, now these actually come in and they decrease the size and the vascularity of the gland. Okay, all your endocrine glands are very vascular. So when they come in to do surgery, decreasing it, shriveled up thyroid gland and the vascularity help with bleeding during the surgery and after. Okay, now back to the drugs. Anytime you give iodine, please, it is nasty. Take my advice. It's disgusting. You need to give it with milk or juice, and the client needs to drink it through the straw because it will stain your pearly whites. Okay, it will stain your pearly whites. Now, another suggestion for Graves' disease is, girl, you need to bring it down. Do you hear me? Bring it down. Let's bring it down with some beta blockers, okay? Yes, that's what beta blockers do. They decrease myocontractility, which decreases your heart rate, and it decreases your blood pressure. Now, that's why this drug is chosen for the hyperthyroidism. Remember, all those things are raised with Graves' disease. Too much action going on. We need to bring it down, okay? Now, don't get a bright idea. It does reduce anxiety, okay? But it also decreases the cardiac output, which could decrease your perfusion. So, be careful when you take it. Please don't take one if you're not used to it and run off to try to take your NCLEX exam. You might not be perfused as well as you need to be to pass your NCLEX. Okay, now, radioactive iodine. Okay, this is one dose, and this is that brachytherapy that we spoke about in the oncology section. It is a sealed that you put in your mouth, so therefore it's ingested, and it not only causes you to be radioactive, but your bodily fluids as well. So, with the radioactive iodine, you need to not kiss anybody for 24 hours, okay? And if you're taking it for Graves' disease, you don't need to kiss anybody for 24 hours anyway. Oh, okay. And you definitely need to stay away from babies, okay? Now, it destroys your thyroid cells. So, the patient on radioactive iodine needs to be expected and watch for a hypothyroidism, okay? Now, this is an expected effect for killing the gland, so please be careful that it's going to go to the other extreme, okay? Now, I also want to let you know that you need to be cautious of a thyroid storm, okay? It's also called thyroid toxicosis and thyrotoxic crisis. Those are three names. And really what happens with it is you have just a tiny piece of thyroid left, and so it gets overwhelmed and just goes crazy thinking that it's got to do all this stuff real quick. And then therefore you've got the hypothyroidism times 100, okay? The increase in the heart rate and the blood pressure are just sky high. And this is a problem. So please keep an eye on that to maybe happen also. Okay, now, the thyroidectomy. This is a surgical procedure where they do a partial or complete thyroidectomy. Now, we always, with every surgery, need to monitor and take care of that suture line, okay? We don't want their head jacked back on a pillow. We don't want them reaching, trying to grab the remote control. So we're going to keep things within their reach, aren't we? So they're not putting any pressure on that suture line. Now, we need to keep the head of the bed elevated. This decreases edema. We need to check for bleeding back here because it might pull back to the back, okay? It might not be bleeding here. It might be pocketed in the back. So please check your patient from behind. Now, nutrition. We need more nutrition. Anytime that we have surgical procedure, we always do better if we are well nourished, okay? Now, this is very important. I need you as a good nurse to assess for any laryngeal weakness or hoarseness in their voice, okay? Now, this could actually mean that they are having laryngeal nerve damage. Now, the laryngeal nerve damage leads to vocal cord paralysis. That's where you're going to have you're going to hear some different stuff going on with those vocal cords. Now, if both vocal cords become paralyzed, you may be dealing with an airway obstruction. We're going to have to trach that person, and we're going to have to trach them fast. So, with the person that has had a thyroidectomy, we need to keep the trach kit by the bed just in case something happens, okay? Now, we need to monitor for swelling there. Inside, outside, we don't want any airway closed, okay? I told you about the recurrent laryngeal nerve damage. Now, also, hypocalcemia. Now, what does hypocalcemia have to do with a thyroidectomy? Well, here's your thyroid, and at the bottom, you have your little parathyroids. And your parathyroids release parathyroid hormone, which actually pulls calcium from the bones and puts it into the blood when it notices that your blood needs some calcium level increase. So, you don't know if their parathyroids have been damaged or have something happened, okay? Now, you can check their serum levels for the calcium level, okay? You also need to be looking for the signs and symptoms of hypocalcemia. Now, when I say calcium, what do you think of? Sedative. Yes, sedative. Calcium and magnesiums are sedatives, okay? So if you do not have enough sedative, what's going to happen? Give me rigid tape, rigid tape. Who's seen Beavis and Butthead? That's how they talk. I don't think their mama must have given them enough calcium, or maybe they didn't stay in the sun enough, or maybe their parathyroid hormones don't work, but I don't know. But they were always rigid tape, they go like this, okay? Now, you can have seizures from that. You can have laryngeal spasms from that, okay? It affects your muscles. Now, okay, I like this part too because I can correlate it to what's going on down at the ballpark. See, this Graves' disease was running around with married men. And so I think of hypothyroidism. It's called myxedema, okay? It's spelled M-Y-X-E-D-E-M-A. And for some reason, I transpose my letters and I think of my ex. And that's exactly what he became, was an ex. Now, imagine the faithful wife is very depressed, sad, because of what has been happening, okay? True story. Now, that is one thing about the thyroid and these hormones that I want you to know, is that hyperthyroidism actually mimics like a manic state. And hypothyroidism very much so can mimic a depressed state, okay? The hypomyxedema person has no energy, okay? Fatigued. Their GI system has slowed down. They're gaining weight, okay? They're cold all the time. You need to teach them to wear layers, okay? Their split speech is slowed and slurred, and sometimes they might not even have an expression, just a dull Eeyore expression, okay? That all mimics depression, right? So this person could actually come in and something could be wrong with the thyroid gland and it's really depression, or vice versa. No, they could think they had depression and it's really the thyroid gland, okay? It actually mimics bipolar, manic, depressive. So anytime someone is actually admitted into the psych unit, they have a thyroid test to see, hey, is this a real physical symptom or is this a psychological symptom? Okay, a psychological problem. Now, if hypothyroidism, myxedema, is present at birth, it's called cretinism. And this is very serious, but thank goodness. The newborn babies are tested before they leave the hospital. Their thyroid function is tested. Yay! Okay, now, with this client, it might just be that they are lethargic and they're tired and they can't get out of the bed, all the way to the extremity of immobile, okay? It can be a wide spectrum here. Now, I love this too. The treatment, of course, you're going to need to give the hormones, right? They don't have enough, something's going on. Levothyroxine is T4, okay? You probably know it as Synthroid. Now, this is one thing that I really like about this. In the middle of levothyroxine is T-H-Y-R-O. Thyro. Right? Not spelled with an I, baby. Spelled with a Y. Right? Spelled with a Y. Okay? Now, thyroglobulin. Now we know globulin means you're not producing it by yourself. We have to give it to you. So, guess what's at the beginning of thyroglobulin? T-H-Y-R-O. And liothyronine. Liothyronine, which is T3, also cytomel, okay? Now, guess what's in the middle of it? T-H-Y-R-O, okay? Not to be confused with the ones that are trying to anti-hormone with an I. These have the Y, and they are giving you the thyroid hormones, okay? These people will have to take these thyroids forever. Now, their energy level will begin to increase. Their heart rate will begin to increase. So if you are given these thyroid hormones, please watch their heart rhythms, listen for changes or anything you might notice, and be careful to assess chest pain. Why? Well, I'll tell you. Because people that have thyroid problems, especially hypothyroidism, tend to have coronary artery disease, and we don't know why. So, when you begin to give those hormones where they've been down, they're going to start to be picking up, okay? So whereas they might not have had a problem with their heart or have noticed pain before, now that it's requiring more and more energy, we might notice a problem now, okay? Now, parathyroid problems. Now, like I said earlier, you have your thyroid gland, and at the bottom it has tiny little parathyroids. They're about the size of a grain of rice, okay? And they secrete parathyroid hormone, PTH. And like I said earlier, that PTH causes you to pull calcium from your bones and put it in your blood, okay? So it's kind of like the thyroid gland does calcitonin, which puts it back into the bones, and PTH takes it from the bones and puts it into the blood, okay? Depending on which area needs it. Now, so if you have too much parathyroid, your calcium level, serum calcium level, is going to be increased. If you have too little parathyroid hormone, your serum calcium level is going to be decreased. Okay? Now, let's talk about hyperparathyroidism. Now, we just talked about if you have too much parathyroid in your body being released, you're going to have hypercalcemia. So, I want you to think of it like this. Hyperparathyroidism equals hypercalcemia. Now, do you remember about calcium? It has an inverse relationship with something. Do you remember what it is? That's right, phosphorus. Okay, so let's put on our thinking caps and think about this. Hyperparathyroidism equals hypercalcemia, which equals hypophosphatemia. Exactly. Now, do you remember what I said about calcium? It is a sedative. That's right. So, if you have hypercalcemia, you have too much sedative. So your signs and symptoms are going to revolve around too much sedative, okay? Now, your serum calcium level is high. Your serum phosphate level is low. Your signs and symptoms are going to be those sedative weakness signs and symptoms. Now, treatment. Now, I saw this. Some of these tiny little grain-like, as big as a rice, can end up being like huge. And they are just releasing this PTH. And they go in and they can take them out. Now, you can do a partial parathyroidectomy or a complete parathyroid connected. Let's talk about a partial parathyroidectomy. Okay? That's when you take out 2 of your parathyroids. Now, expect the PTH to be decreased. That's what we want, okay? But we've got to monitor post-op the bottoming out hypocalcemia, okay? That's why we're taking them out. We have hyper. When we take them out, we need to watch for hypocalcemia. Now, what were some of the signs of hypocalcemia? Not enough sedative, rigid, tight, rigid. Remember, rigid, tight muscles. Now, on the other side of that coin, hypoparathyroidism. That's not having enough PTH be released, right? So, hypoparathyroidism equals hypocalcemia, which equals hyperphosphatemia. Inverse relationship, remember? Okay, so if you have hypocalcemia, that means that you do not have enough sedative, okay? Not enough PTH causes your serum calcium level to be low, your phosphorus level to be high, and the signs and symptoms are not sedated, rigid, tight, not sedated, rigid, tight, okay? Now, treatment. I know. What if we gave them some calcium? Bing, bing. Good job. Now, there's something that we have to remember when giving IV calcium. Give it slow and make sure your person is on a heart monitor, okay? That whole influx of calcium and outflux of potassium and muscle and just please make sure they're on a heart monitor and give it slow. Now, remember this inverse relationship that we're talking about? So we can actually alter the levels of calcium by altering the level of the other. phosphate binding drugs. If we can decrease the phosphate, we can increase the calcium. If we can increase the phosphate, we can decrease the calcium. So in this instance, we would talk about those phosphate binding drugs, which would increase our calcium. Phoslo, Oscal, Renagel. Those are some of those names that we've talked about before. Okay? Now, let's talk about the adrenal glands. Now, when I think about the adrenal glands, I have a great thing. I think about the Jeffersons. Those who are old enough remember the Jeffersons. I don't know if everybody does, Samantha, because you're so young. But the Jeffersons, moving on up to the sky in a deluxe apartment in the sky. We're moving on up to the sky. We finally got a piece of the pie. You remember, don't you? Now that's free. I gave that to you for free, okay? Now, why do I think of the Jeffersons? Because the adrenal glands are the penthouse of the kidneys, okay? The penthouse. And what happens when you live in a penthouse? When you go from being poor to being rich? Well, one thing is, you're not quite as stressing, are you? You're not stressing about your food. You're not stressing about your bills. Okay? And that's exactly what the adrenal glands do. They handle stress in the body. Okay? Now, you have two parts to your adrenal gland. The adrenal medulla, which is the middle, medulla, middle. Okay? Then you got the cortex, which is the outer capsule layer. Now, the medulla we're going to talk about first. It secretes epinephrine and norepinephrine, okay? That normal chemicals that come out when you are in a stressful situation. Now, some problems with that medulla is pheochromocytoma. And I love that word because it's kind of long and I can pronounce it, and it's just fun to say. Pheochromocytoma. Okay? Now, and what this is actually benign tumors inside that medulla that causes bolus squirts of epi and norepi. Okay? So, you know all the things that happen when epi and norepinephrine are released in your body. Vasoconstricting, your heart rate goes up, your blood pressure goes up, your blood is shunted to your organs, your GI system clank locks down. There's a lot of things that happen. So, I would hate for constantly just epi, norepi, blah, blah. Okay? And that's what this tumor causes. Now, it's going to cause your blood pressure to increase, your heart rate, your pulse, flushing, diaphoresis. Now, I love this too. This is the test that they test. It's called VMA, vanilla mandelic acid test. Vanilla mandelic acid test. VMA. I will never call it VMA because I love to say vanilla mandelic acid test. Okay? It really reminds me of my favorite band, Milli Vanilli. Now, just as the name suggests, please refrain from vanilla flavoring and vanilla foods for about a week because that's going to alter your test. Now, this test is a 24-hour urine test. So you know, with a 24-hour urine test, the time it starts, the time it ends. Say it starts at 9, you have your first void, you dump it, you get rid of it. You go for 24 hours collecting every single drop of tea, right? TT. Until the very last voiding, you keep that voiding, and you turn your test in. Now, they are looking for how much epi and norepi are in this test. So if you are like smoking up a storm and jogging around and exercising and fighting with the girl at the ballpark or the boyfriend, okay, it's going to cause a lot of epi and norepi to be in this test. Rightfully so. We're not looking for rightful epi and norepinephrine. We're looking for those boluses that just shoot out. Okay? So this is going to alter the test. You're going to have to stay calm. Don't put yourself in a stressful situation for this time period. Okay? Now, we will have to have surgery to remove these tumors that are causing these boluses of epi and norepinephrine. Now, let's talk about the adrenal cortex, okay? Now, the adrenal cortex is what actually releases the glucocorticoids, the mineralocorticoids, and the sex hormones, okay? Now, let's talk about those glucocorticoids first. When I give steroids, these are the 4 main actions that I've got in my noggin about these. First, they will alter some moods, okay? It can be all the way from being extremely depressed to being euphoric, okay? The change in mood can be variable. So just some examples could be like insomnia or psychosis, depression. Like I said, you're euphoric. So change in mood, okay? Number 2 is they do alter your defense mechanisms. You know that if you are on steroids, your white blood cell count can be decreased. You are going to be immunosuppressed. You're going to have trouble healing, okay? High risk for infection. Number 3, they break down fats and proteins. You are going to see some ketones because steroids break down fats and proteins. They also inhibit insulin. Hold up. Listen, you're not diabetic, honey. You just have high glucose levels right now because you're on the steroids. We're going to give you a little insulin to deal with it. As we taper you off, that should come back into check, okay? Notice I did say taper. Don't just stop. Now, let's talk about the mineralocorticoids. Mainly aldosterone is what I want to talk to you about. And we have talked about aldosterone already. Aldosterone causes you to retain, and that's right. And now we're going to say it also causes you to lose potassium. Okay? So, if you have too much aldosterone, you are going to be in fluid volume excess. Too much sodium, too much water, and not enough potassium. Okay? It's an opposite. Here we go. Inverse. If you don't have enough aldosterone, okay, you are going to be in a fluid volume deficit. Okay? Not enough sodium, not enough water, and too much potassium. Now, as far as the sex hormones go, we're going to touch on that when we talk about Cushing's. Cushing, Cushing, Cushing. Okay? Now, let's talk about the adrenal cortex problems. Now, I like this one because I think of Addison's disease. Okay? If you don't have enough ALD for aldosterone, you need to add ADD. Addison's. Okay? Now, Addison's is adrenal insufficiency, not enough steroids. Now, when you do not have enough aldosterone, what are you experiencing? Fluid volume deficit. Think shock. Anytime you hear fluid volume deficit, think shock. Okay? Now, just like I told you though, when you don't have enough aldosterone, you're getting rid of all your sodium and water and you're retaining potassium. So, with Addison's, you got some serious stuff going on. You got a lot of potassium and not enough fluid. Now, the signs and symptoms initially are going to be because of the hyperkalemia, okay? But it can go on into anorexia, nausea, the skin can be bronzed, you can have like white patches, hyperpigmentation, depigmentation, decreased bowel sounds. I told you about the GI upset, hypotension because you're losing sodium and water, and hypoglycemia because steroids actually help move. What do they do? They put potassium into the cells, steroids do. Oh! They cause you to inhibit your insulin, remember? Now, the treatment for this, Addison's, the cortex problem, is that we're going to have to combat shock, okay? That's a biggie right there. So they're losing water, they're losing sodium. We need to increase sodium in the diet because if sodium comes, water comes, right? If water comes, sodium comes, right? Okay? Things like processed fruit juice and broth have a lot of sodium in it. Now, it's a water problem. We're going to have to do those I and O's, keep up with that daily weight, right? Now, if they're losing sodium and water, their blood pressure is probably going to be down. Their weight's going to be down. They're going to be in fluid volume deficit. Bing, bing. Huge nursing diagnosis for Addison's disease. Nursing volume deficit. They will be put on a mineral corticoid called fludrocortisone, which also is known as Florinef, which is just aldosterone. Okay? Now, with this medication, we want to keep the patient within 2 to 3 pounds of their normal weight. Okay? So, with this medication, with these steroid medications, they will constantly be altering their level, decreasing the amount, increasing the amount. Okay? Sort of like insulin. Depending on how much you weigh, depends on how much you get that day. Okay? The dose is always changing with these steroids. And like I mentioned earlier, never stop taking your steroid abruptly. We have pretty much put the glands to sleep by giving this steroid. So if we take it away abruptly, the glands are still sleeping. So they're not going to pick up the slack. They need to be tapered off and wean it back into happening, okay? Now, let's talk about Cushing's. Cushing. Why do I do that? I'll tell you. Cushing's is actually too many steroids. Too many of all the steroids. The glucocorticoids, the mineral corticoid, and the sex hormones, okay? Now this is where we're going to talk just a teeny bit about the sex hormones. They have too much of all these things. So, what are some of the things that's going to be happening with too many glucocorticoids? Okay? Well, for one, we know that they're going to have that psychosis to depression because of those mood alterations, right? They're going to have hyperglycemia because those steroids inhibit insulin, right? They're going to have a growth arrest. Now, they're going to have like that moon face. They're going to have truncal obesity, hence the Cushing. Okay, that's why I say that. And a buffalo hump back here, because that's all that fat distribution, okay? It's being distributed different areas, to the back, to the hump, that kind of thing, okay? Now, let's talk about too many of the mineral corticoids, okay? The main one we're talking about is aldosterone, right? So, with too much aldosterone, fluid volume excess, increased blood pressure, congestive heart failure, weight gain, right? Now, too much of the sex hormones are going to be things like oily skin with acne. The women can have a beard and have male traits, and a decrease in libido. Now, since the client has too much mineral corticoid, this is what we're really focusing on, okay? So too much means they are going to retain sodium and water and lose potassium, okay? Now our potassium level is too low. You need to be monitoring that. If you did a 24-hour urine, you would expect the cortisol levels to be increased, correct? Now, the treatment is an adrenaledectomy, okay? Now this can be unilateral or bilateral. Now, you cannot live without steroids, so expect if your adrenal glands are removed, you are going to have to take steroids lifelong. and you know the problems they cause. First of all, steroids help handle stress. So, for the people that are not producing enough steroids, any itty bitty tiny a bit of stress cannot be handled, okay? So we need a quiet environment. We need to help this person out. Now, the diet pre-treatment, of course, we need some potassium, right? We need a decrease in sodium. We need our protein to be increased. Why? Because steroids break down protein. Now, what about the calcium? Well, I'll tell you. A hint. Steroids decrease serum calcium by excreting it through the GI tract. Now, I didn't tell you that at the beginning when I told you those 4 major functions, did I? But it's true. Steroids actually decrease calcium by excreting it out of the GI tract, okay? Which could mean if you're excreting your calcium and PTH is going to the bones and getting more, and you excrete it because you took more steroids, and PTH is going to the bones to get more, and this just keeps happening, brittle bones, osteoporosis. Being on steroids for a long time might be necessary, but it might cause some other adverse things to happen. You need to avoid infection, okay? Remember, too many steroids decreases your immune function. Now, what might appear in the urine? Well, please don't say protein, because unless you've got something wrong with your glomerulus, protein's not, it's too big, it's not going to come through. But we will see some ketones and glucose, okay? Because steroids inhibit insulin, which means we got to build up of glucose in our urine. We will also see ketones. Why? Because steroids cause the breakdown of fats and proteins. Now, we will begin the second part of this lecture on diabetes momentarily. Thank you.